I've chosen this case because it was very challenging. What happened, it's the patient who presented to us last summer. It's an 80-year-old patient, a retired senior servant, which came with a history of 5 days epigastric pain and nausea and fever. She'd already been seen by her GP and who ordered an ultrasound and confirmed an acute calcular cholecystitis. He already started her on ciprofloxacin as well as all her medication. She had a long medical and surgical history: diabetes, hypertension, hypercholesterolemia, GERD, rheumatic pain, and vertigo. She was well controlled on all the medication on which she added an aspirin. Also, from the surgical point of view, she had a tonsillectomy, uterine prolapse, and bilateral breast cancer 9 and 11 years ago, for which she had a conservative breast surgery and adjuvant therapy. She was hemodynamically stable, epiraxial, some tenderness in the right upper quadrant, and normal bowel sounds. And she already had a CT chest for another reason. They thought she was in contact with a corona patient, but she's completely normal. And what we did at the time, we changed antibiotics into third generation of the age and stopped the aspirin. And we saw her 48 hours. She was much better. Pain scale was 8 to 5, and she started her back to her normal activity. She was looking after her disabled husband. Very slight tenderness, but the laboratory showed that she had a CRP elevated, the bilirubin was normal, and the liver enzymes were elevated, 2 and 5 times the normal, and normal amylase. And possibly you agree with me, for this situation improvement, we carried with the conservative treatment, especially that she was on aspirin, and to see her in 4 weeks' time to plan for an interval cholecystectomy. 10 days later, that's day 17 from the onset of the symptom, she had a severe exacerbation of the pain, not settling by non-steroidal, and she had to be admitted as an emergency. Marked tenderness, the leukocytic count went up, the CRP was up, the bilirubin was 2.7 over 1.9. For those who are not familiar with the milligram per deciliter, the normal value, the fractionated bilirubin total is 1 and direct is 0.2. The transaminases were still elevated, and alkaline phosphatase and the gamma GT at least 8 times the normal. The repeat ultrasound showed this time that the CBD was 10 millimeter, and there was a thin ring of perihepatic fluids and a right pleural effusion on chest X-ray. So we switched to combination of antibiotics, carbapenem and metronidazole with all the medical treatment, and we ordered an MRI study and MRCP. Already by 2 days, slight biochemical improvement, but the leukocytic count and the CRP went even higher, and she started feeling some episodic dyspnea with the falling of the oxygen saturation, improved immediately by even small amount of oxygen. And we got the advice of the pneumologist who said that there is no evidence of COVID-19 or pulmonary embolus, but it was all secondary to the presence of the fusion. This is the MRCP picture, which showed obviously the hallmark was the rim of perihepatic fluids between 2 and 12 millimeter, but 12 millimeter in thickness with turbid fluids. And looking into more details, there was still a distended gallbladder. There was a dilatation of the intra and extrahepatic bile ducts up to 11 millimeter. The lower end was smooth and tapering, but no stricture, and attributed it to possibly edema of passage of stones. The pancreatic duct was normal. The pancreas was slightly atrophic, consistent with the age. The liver showed no focal lesion. You can see the cystic duct with low insertion, but lower end of the CBD, there was 2 shadows possibly representing stones. So this is the report of the MRI. So no evidence of recurrence of the tumor, but acute cholecystitis and subphrenic collection and calcular obstructive jaundice. So that's the acute presentation, complicated calcular cholecystitis, presenting with 3 complications at the same time on the background of an 80-year-old patient, slightly pre-obese, with a lot of long medical and surgical history, but with all controlled. And the next question, what one do in a situation like that, facing 3 complications at the same time? I will stop to see what's your opinion before proceeding, and just mention all the options that I can think of. Should one go to surgery, cholecystectomy with without exploration, interventional with the ERCP and trying to clear the duct interventionally, or doing a percutaneous drainage, or possibly a combination, with which order, or if you have any other suggestion. I will stop a few minutes and listen to what your opinion, what would you do in a situation like that?
Any comments?
Hello, Rachid. All due respect, this is why I think when you have an acute cholecystitis, you need to take the gallbladder out before the patient goes home. This is an example of recurrence of an acute problem that you would have probably been easier to deal with previously, hindsight, but just that's my only comment.
Yes, well, I agree. Actually, she came after 1 week. She was on aspirin. She was not prepared. And until we get all the assessment, she already saw some improvement, and she was getting better and back to normal. And we felt at that time that it would be wise to offer her an internal cholecystectomy rather than going in a difficult time between the 10 days and 21 days. But I agree, this should have been, if you'd come early in the first day or 2, we'd have proceeded with that.
I think that at this moment, with the ability to do laparoscopic cholecystectomy and intraoperative cholangiogram, that will be the best thing to do, unless somebody has any other opinion. I don't see a reason to open this patient. I don't see a reason to do an ERCP. The cholangiography will allow you to extract a stone if there is one, or if you don't want to do that, just simply do a cholecystectomy and the patient have an ERCP after. Hold on a second. Any other comments? Go ahead.
Okay, so in fact that was an option, and what we proceeded with, the anesthetist was not happy immediately to put her to sleep view of this dyspnea and this effusion. So we bought time to do an ERCP, and initially we thought it would be the cholangitis, but we did it very carefully, and we aspirated all the bile, and you can see the bile was clear. The next was to do the extraction and stone scam and tiny gravel. And after doing that, it completely drained. So there was no point of doing a biliary stent. Post-procedure, the amylase didn't go any significantly higher. So we proceeded to surgery straight. And we preferred then open view of this perforation. And I think, as you could see, it was the right decision in this particular case. The anesthetist insisted that we do the tapping of the pleural fluids. He was not happy to put her to sleep, and this was done just before the induction. And so an upper midline. First thing we found a distended transverse colon. There was a lot of adhesion in the right upper quadrant around the gallbladder, and then we found after the adhesiolysis that the gallbladder was perforated and the end was necrotic. Also, it wasn't shown, but the leak had gone to the generalized peritoneal cavity, and there was a generalized peritonitis. Just a brief diagram to show exactly what happened. An severe, acutely inflamed gallbladder with necrosis and gangrenous. Initially, it showed a localized perforation and subpharetic collection, but progressed to generalized peritonitis. So what we did actually was done a peritoneal lavage completely and the drainage of the abscess, and we did a retrograde cholecystectomy and with a final lavage and continue the treatment. That was the picture of the gallbladder from the outside, acutely inflamed with gangrenous tip, but when we opened, it was the most gangrene of the most distal part. This is the stump of the distal cystic duct. In fact, post-operative, she did very well. She only stayed 24 hours in HDU and went to the wards the following day, regained intestinal transit and removed the drain starting from day 5 after she had a normal diet. The peritoneal fluid showed that, and the bile was a Klebsiella, sensitive only to trinam, but resistant to quinolone and cephalosporin. And the histopathology showed the hemorrhagic cholecystitis with gangrene. We saw her 6 weeks, 3 months, 6 months, and a year, just last month, and she was absolutely fine, back to completely normal. Some wound pain for a few months, but she recovered well. And the biochemical and the laboratory profile was all normal. The slight rise in CRP possibly attributed to her rheumatic pain. So the conclusion that we've reached, we faced a situation where you have 3 complications at the same time. We couldn't find any publication to say a situation like that. All the discussion was when to do the clearing the duct, whether to do it before or after immediately, whether laparoscopic or by ARCP. I think we went step by step, and a case like that, we just to assess it as individual case. She was an ASA2, and she was ready to have an open surgery. But obviously, we did the clearance of the duct first, and we reassessed her step by step. She didn't show any signs of pancreatitis, so proceeded with surgery. If she's developed pancreatitis, which could have happened in 20% of cases, we'd have reverted to percutaneous drainage and later on surgery. The next point was the cholecystitis in diabetes mellitus, and a lot of publication, but they all agree that there is a higher incidence of complication in diabetic. The deceiving side or the tricky side was the gangrene can settle with a lack of cardinal signs completely, without any signs. And there was a report of patient being admitted with diabetic ketoacidosis, and after being while treating, they found that the cause was gangrenous cholecystitis. And if perforation happens, the curve of the mortality and morbidity goes up. And if it goes into multi-organ failure, the mortality can reach up to 22%. So always be aware of a diabetic patient with a raised leukocytic count. She didn't show that in the start, but later on, and altered liver enzymes, especially those who have a neuropathy. And I think in all cases, it has to be an accurate assessment and, as you suggested, an early intervention. Thank you very much for this presentation and for all the attention, for the attendance and attention. And I would like to listen to any of your comments.
Thank you, Rachad. We appreciate your presentation.